This is Module 1, Part 2. In Module 1, Part 2, in this section we'll have two skills that are important. One is the measurement of axis and one is the measurement of rotation. And we'll go over several examples of how this works, again, through the small text in the course spec. First of all, axis is in the where you look at the frontal plane only. So we only have to use leads 1, 2, 3, AVR, AVL, and AVF. Or some people would say 1, 2, 3, R, L, and F, just those 6 leads. And we are trying to determine what's called the mean ventricular depolarization vector, MVDV, on the person, where that is. And so if you, again, take page 6 in the course pack, in the text, page 6 in the text, and place that circle over your chest. If you, and I'm doing that to physically do that, you'll have, for example, where it says 0 in lead 1 in the black dot, this will be projected to your left side. It ends up being over, left of your body, left side of your body, about mid-chest, and then the circle lines up from there. So we are interested in the axis or direction of this vector in that circle. So if you had, for example, sticking with that 0 point, if you took a maybe pen or pencil and projected it right at 0, that would be the axis of your heart, where it's pointing. And that's what it means, is where the main depolarization is going, or the mean ventricular depolarization vector is going in that direction, like that. If you, more of a normal direction would be about 60 toward that black dot. That's the black dot of lead 2. So if you take your pencil or pen and put it on the circle over your chest and point it towards 60, that's more of the common direction. But it really can be anywhere on the circle. But 60 is the most common direction for the MVDV. This, and we'll determine how to do this from the EKG, or how to actually determine where the axis is. But first off, the MVDV depends on, could be the anatomical location of your heart. Is it tilted a little bit one way or the other? A lot of times in, say, pregnancy, the heart will tilt more to the left. It kind of pushes everything in the uterus, pushes the heart up to the left. And so it could be an anatomical thing. A lot of times with real tall, lean individuals, the heart tends to tilt a little bit more toward vertical, or more toward, if you're looking at the circle, almost down toward the 90-degree area. So it could be the anatomy, or maybe just where your heart was positioned upon birth. Another thing is hypertrophy, keeping the heart where it is. Axis will go toward hypertrophy. So, and this is one of the important things with axis, is that if you have, say, left ventricular hypertrophy, your axis, not your heart anatomically, but your axis will be shifting toward hypertrophy. So maybe before you had the hypertrophy, you might have had an axis of 60, and then you have hypertrophy, and now you have an axis of 0, like that if you have left ventricular hypertrophy. So it goes toward hypertrophy. If you have infarct, the axis tends to go away from infarct. So if you have, say, an infarct on the left side of the heart, your axis might be shifting to the right a little bit, away from that infarct. And so axis goes toward hypertrophy and away from infarct, and these are some of the causes of why you would have an axis that's different from one person to the other. Hemiblock is another thing that will shift axis, and I don't want to talk so much about that right now, but in a later section in the course, we'll be talking about axis with regard to hemiblock. And hemiblock is where you have a conduction system defect on the left bundle, one of the parts of the left bundle, but again, later on that. So that's pretty much a introduction to axis on that slide. If we go forward then to how to actually measure the axis and the explanation of this, and this is determining the axis is kind of the fun part, or a skill with EKG. So if you want to look at a 12 lead to determine axis, and you actually just need 6 of those 12 leads, 1, 2, 3, and R, L, and F. Those 6. You don't need B1 through B6. And we're trying to determine something called the isoelectric lead. I'll go into how to do that. There's an example on the next slide. We got the course pack, page 3, and then we'll come back to the text on this on pages 6 and 7, and then do some practice with this too. And again, feel free to pause at any point and think about, try these skills. Let's begin with page 3 in the course pack. Because it maps it all out, has the circle on the top. You want to be able to work with the circle and know how this works. The circle by convention is always negative on the top half and positive on the bottom half of that. And so what you do then, step by step, is find what's called the most isoelectric lead. And this would be the lead where the R and S wave, and we'll talk a little bit about Q wave later, are not projecting up or down, but they're kind of equal. And this is something that, again, you can pause and let this settle in, and we'll do several examples. But on this example on page 3, leads 1 and 2 are clearly, QRS complex is clearly up. It's, almost all up in that case. In leads 3, ABR, AVF, it is down. So we don't want to use those leads as our step 1 isoelectric lead. The most up and down, or most equal situation here is AVL. It goes somewhat up, somewhat down. So that's our isoelectric lead. We found that. And then you want to, and again we'll practice this more, you want to find the perpendicular lead to that. You can look on the circle and you could look at the perpendicular lead based on that. The other way to do it is that lead 2 is always perpendicular to AVL. And lead 1 is perpendicular to AVF, and lead 3 is perpendicular to AVR all the time. So you can just memorize that, or again, you can use the circle. But 1 and AVF, 3 and AVR, 2 and AVL, like that. That's kind of a way to think of it. And so back to this example then, the perpendicular lead to AVL then is lead 2. And when we have lead 2 then, we go to step 3, lead 2 would either be up or down. If it is up, you follow it right toward, and this is back to the circle, lead 2's positive electrode, or black dot in this case, in the book on page 6, and the axis would be 60. And that's the case here. Lead 2 is up, so the answer on this is 60 degrees. You want to come up with a degrees answer for axis. If lead 2 ended up being down, like all Q and S wave mainly, then you would go completely away from lead 2's black dot, or where it's positive, and take it all the way up to negative 120. That's not the case here. But if it did end up projecting down, you would take it to negative 120 for the axis. And so that's how to do that. Let's do another one together. Page 3 is a good kind of step-by-step technique. If you go to, let's go to the next slide together. Look at that and be looking at that together. In finding the isoelectric lead, I would say that leads 2, 3, and ABF project up, mainly. So I do not want to use them. Leads AVR and AVL project mainly down. So again, I do not want to use them. Clearly the best choice is lead 1. That projects up and down close to equal. Not perfect, but pretty close to it. So choose lead 1 for step 1. And then you find the perpendicular lead. And again, it's 1 in AVF, 2 in AVL, 3 in AVR, like that. Always line up as perpendicular. So the perpendicular lead here for us then is, on this example, is AVF. And AVF is projecting upright. So our axis, in this case, the answer is 90 degrees. If AVF projected down, the answer would be negative 90. But it's projecting up, so the answer is 90 degrees. So it's a way to get axis, and again, feel free to pause and get the technique down. But those are a couple of examples. If you look at the text, again, we're looking at that on pages 6 and 7. The main thing is to be thinking about that circle. If we go back to the course pack on some more practice, we can look at pages 4 and 5, and we got answers on the next slide. But again, go through and try these, and you can determine where the most isoelectric lead is, and then determine perpendicular lead, and then is the perpendicular lead up or down, and then if it's up you go to the positive, if it's down you go to the negative side. So you can pretty much do these on your own, but let's try the top one on page 4 as an example. And I would choose AVF. And maybe you've paused me by this point, you've gone ahead and tried this, and lead 1, then you go to lead 1, and that's upright, so your axis should be at 0, and that's if you go a couple slides forward you see the answer at 0 like that. And so that gives you some practice. Bottom of page 4, pretty straightforward. Again, top of page 5, pretty straightforward. Come up with those answers. The bottom of page 5 is actually one that's beyond the scope of this course, so it's not testable, but sometimes you can use a couple of different leads and then take the average of them. So I'll talk you through the bottom of page 5, but again, that's outside of the scope of this course. I would not use leads 1 or 2 or AVR or AVL. Those I would not use as isoelectric. But leads 3 and AVF could be considered, or you could argue one or the other. So if you do it with both of them, if you end up doing this with AVF, you end up with an axis of 0. If you do it with lead 3, you end up with 30 degrees. Because again, you have to go, AVR's down, so you go away from AVR's positive, and you got 30. So this axis is actually, you take the halfway between 0 and 30, you got 15, like that. So you don't have to be tested on that for this course, but that would be a way to come up with something that's not right on a line like that. So anyway, this slide, which is number 1 on axis, shows you the technique and gives you some practice, and then you got to practice EKG in the next slide, and then you got the answers from the course back on the next slide like that. And that's the technique on axis. If you do have to the next slide then, if you do have a Q wave, you can have that be a part of the S wave. So the Q and S wave go together as a downward deflection, and you compare them to the R wave. So that could be added in on this too. And then if you look on page 7 in the text, you can see at the upper right, the normal area is -30 to 90 degrees. That's normal. And then -30 to -90 is left axis deviation. +90 to 180 is right axis deviation. And then you have your quadrant of marked right axis deviation too. So those, you end up having this in, a normal or left right or marked right like that. A vertical axis would be straight down at 90 degrees. And again, that happens sometimes anatomically and sometimes in tall, lean people. They can shift toward vertical. And then horizontal is considered to be at 0 degrees. And this happens often in somebody that's overweight because it pushes the heart more toward that horizontal area. Or if you have somebody, a female who's pregnant, and with all of the growth of the fetus, embryo fetus, baby, below the heart, that tends to push the heart actually physically to the left and up a little bit during the pregnancy. Now, upon delivery, this will be reversed and the heart drops back down where it was. But that would push it toward what's called a horizontal heart and more of like a 0 degree type heart for that. So be aware of those areas and what that means. And again, page 7 at the top really is a good look at that in the text. All right, so that's the Hexus technique. The final piece of information and skill for this module, and therefore for test 1, is called rotation. So on the outline, this revised outline, then number 2, rotation. This is another technique or another skill that you'll have to determine how the heart is rotated, and I'll talk about how that works. In the end, you end up with 3 possible answers: normal, clockwise, or counterclockwise. So come up with one of those answers, and we'll look at how to do that on this. If you have your patient, visualize this, have your patient lie down on their back on an exam table, and then if you look from their feet, look from the bottom of the feet through the top of the head. So you can have a person lying down and physically get to the level of their feet, look at the bottom of their feet or shoes, and look right through them all the way to their head is the rotation. And if you could put a clock on their feet, just put that right on their feet, then you can see where you have rotation based on that clock. You got a clock right on the bottom of their feet, and you're looking into that clock for the rotation. If you think in terms of leads V1 through V6, these are the ones you use. Don't have to use anything else. And put them on that clock, you're going to see that V1 is toward the upper left area, and then it kind of goes around the clock to the right and down as you go down to V6. So visualize, say V1 would be, at maybe roughly like a 10 o'clock position, and then V2 you would come down to more like a 1 or 2 o'clock position, and then V3 you drop down to like a 3 o'clock, 4 o'clock, like that type of thing. So that it's on the feet as part of the clock, like that. So what you're looking at then is for 3 possible answers is you're looking at where in V1 through V6 where you make a transition from having an R wave that's smaller than the S wave to an R wave that's bigger. And the best way to think about this is to look at page 7 in the text, toward the bottom. And you can see that the author, Dr. Bing, has shown an R wave that's smaller than the S wave in V1. That's how it should be, actually. It's on the right side of the body, so the R wave is smaller. But the R wave, if you look at V2, starts to grow. It's bigger. But it's in V2, it's still smaller than the S wave. And then by the time you get to V3, the R wave is bigger than the S wave. And that's a normal area. You made a transition from R wave in V2 that's smaller to an R wave in V3 that's bigger. You made a transition. And that's that normal. So you would call that on page 7 at the bottom as like a normal transition. Now what if you had, and normal would be between V2 and V3 to make your transition, or right at V3. If V3 ended up being equal, R wave and S wave, then you would call that normal also. That's the normal area. Use the word normal. If you have a situation, and we'll look at examples where the R wave is smaller in V1, smaller in V2, smaller in V3, and doesn't become bigger until V4 or later, that's what's called clockwise rotation. And you can also call that late or left, but mainly the term is clockwise rotation. And so you haven't had your transition until later, and that would be clockwise. And so anything past V3, just past V3, between V3 and V4, it's usually considered to be slight clockwise, but if you get even later in the EKG, then that's clockwise. So say, for example, you got to V5, and your S wave was still larger than your R wave. And then finally in V6 your R wave became larger, real late. That would be clockwise rotation. We'll look at some examples. Now on the other side of this is if you have, let's say you have an R wave smaller than your S wave in V1, but then you go to V2, and all of a sudden your R wave is larger than your S wave in V2. Shouldn't be that early. And so what you have then is it's happening early or to the right, and this is called counterclockwise rotation. So again, if you had an example where, I'm kind of looking at page 7 as I describe this, but if you have lead V2, the R wave is actually bigger than the S wave. It shouldn't have happened that early. Then you have counterclockwise rotation. Anything to that side of it would be counterclockwise. And that could also give you a possible tall R wave in V1, which is abnormal. So that's counterclockwise. And so I think the best way to do this, and we're kind of winding down with this whole module, is to look at some examples and then look at some implications of this and then go to a review from there. So if you look at pages 6 and 7 in the course pack, and we have, if you go ahead to the next slide, which you may not want to do right away, you can test yourself on this, and you may want to pause me as I go through these too. I think I should go through all of these on pages 6 and 7, but hopefully you'll do this on your own first, and then before we get the answers. So on the page 6 at the top, we're looking at V1 through V6, part of the 12 lead. And again, we don't need the whole 12 lead. We just need these leads. We can look at a whole 12 lead, but we just look at V1 through V6. And we're seeing that the R wave in V1 is smaller than the S wave. V2, it's smaller. By V3, it gets to be bigger. And so the transition occurred between V2 and V3. Your answer then, of the three possible answers, would be normal. That's a normal area. If you look at the bottom of page 6, and this is a 12 lead, but you can ignore leads 1, 2, and 3 and RL and F. You can ignore them and look at V1 through V6. You can see that the R wave is smaller than the S wave in V1, V2, and V3. By the time you get to V4, the R wave is bigger. So the transition has occurred between V3 and V4, and that's considered to be very slight clockwise rotation. It happened a little bit late, so slight clockwise. If you look at page 7, and again, pause me at any time, your R wave is smaller in V1, V2, V3, and then slightly smaller than the S wave in V4. Pretty close, but slightly. And then by V5, your R wave is bigger than your S wave. So your transition here has occurred between V4 and V5. That's quite late, or to the left, and therefore that's considered to be definite clockwise rotation. If you look at the bottom of page 7, the R wave is smaller than the S wave in V1, which it should be. But when you get to V2, the R wave is bigger than the S wave. And that's, that transition which happened between V1 and V2 happened very early and to the right. And that's considered to be counterclockwise rotation. So hopefully, when you get your exam on this, you'll have an EKG on rotation, and you'll come up with one of these three answers. And you should be able to, use that transition as a way to get to the correct answer. So that's the way to do rotation. If you go forward to the next slide, what are some of the implications? If you have clockwise rotation, which would be like page 7 at the top, then this is also referred to as poor anterior R wave progression. It's not progressing like it should. And you can see that written on the slide, and I just read that off the slide. It's poor progression. This actually mimics something called an anteroseptal wall MI, or infarct, myocardial infarction, and kind of looks like it. So if you have and we haven't studied that yet, but if you have a patient with this type of rotation, clockwise rotation, you would consider that, look at maybe past EKGs, do they have clockwise rotation, or do they have they had an anteroseptal wall MI? It's what's called a differential diagnosis in medicine. And you might have a point where you would say, could be one or the other. I don't know. But a lot of times you can get more information to determine which one it is. So initially, like at the top of page 7, I could say, this could be clockwise rotation, or it could be a previous anteroseptal wall MI. I want to look into it further. So it kind of mimics that. The rotation itself is harmless. The infarct is definitely clinically significant. Counterclockwise rotation then mimics a posterior wall MI sometimes. And this is where if you're putting a lot of R wave into those early precordial leads like V1 and V2, especially if the R wave is bigger than the S wave in V1, that can look like a posterior wall MI on the back of the heart. And again, the counterclockwise rotation is no big deal, but the posterior wall MI is an important item clinically. So you might have an EKG, and this is usually a situation when the R wave is bigger than the S wave in V1. You could say this could be one or the other. Let's look into it further. Could be counterclockwise rotation, or it could be a posterior wall MI. And there are ways you can find out by looking at past EKGs, blood tests, nuclear imaging, things like that. But for now in this course, just consider that the counterclockwise rotation mimics a posterior wall MI potentially, and I'm just reading off the slide. Another term here is dextrocardia. This is where the heart is tilted to the right side of the body. This doesn't happen very often. In fact, clinically, with all the patients I saw over the years, I only saw this myself 3 times where the heart was tilted that way. And what it means is The heart tilts that way, and the liver, which is on the right side, is actually placed over onto the left side of the body. This is something you're born with, dextrocardia. And if you have this, you're going to get an unusual pattern when you put on your electrodes, and you end up actually putting you should put your electrodes ultimately down the right side of the body to look at dextrocardia. But that would give you, initially when you looked at it, you'd see kind of a funny rotation on that. And that's really more just out of interest than anything to add to this course. So those are some of the implications of rotation. Rotation is the last topic on this exam or this module. And now I would like to talk briefly on this next slide about just a little expectation or review for exam 1. All the material in the module is testable, unless in some cases I said future learning or maybe not testable. For example, we talked about that one axis that was 15 degrees where I said that was outside of the scope of the course, but pretty much everything that I've talked about here is testable for exam 1. You'll have 20 multiple choice true-false type questions. There'll be 2 points each for 40 points. And then you'll have critical inquiry questions, including skills, EKG recognition questions worth 60 points. So what you'll be doing on this then, on these critical inquiry questions, is looking at, mainly looking at these EKGs and determining things like, like what we just did, for example, what's the rotation? What we did before that, the axis, determining the rate, the rhythm, the intervals, stuff like that, all the skills you've had in looking at EKGs and coming up with that information. And then also another area in critical inquiry could be even like labeling the different waves and intervals and items along those lines too. So, and you could talk in terms of, again, what we've seen in the course pack and in the book, and coming up with that material. So that concludes Module 1, which is in 2 parts, and that concludes the information for Exam 1.